tell us about.
All right.
Okay.
So just a little background for the folks who don't know. We've been talking about this PPRL hashing for, over a year now. And we are ready to launch. And so I want to just let people know where we are. And some of you all are going to start getting pestering emails from me. And so I just want to just remind people a little bit about PPRL. If you didn't know what it is, it's privacy preserving record linkage. We're using it for three things: patient deduplication, multiple data set linkage, so different types of data set, and for cohort discovery. This is a de-identified linkage system. So that means there is no data PII that is used for the linkage. It's so important. For the folks who have not heard about this, everybody, all the sites, except for just a few new ones who've signed on recently, who've signed a DTA, have been sent the Honest Data Broker, Honest Data license, and it's a three-way license between NCATS, the data contributing site, and Regenstrife, because Regenstrife is the honest broker. And what we did is we did put some principles in here, just to remind people it's completely voluntary. You do not have to participate, but if you do participate, what you're agreeing to participate in at minimum is deduplication, because we consider that to improve the data quality, and we feel that's a minimum. But there's two other things that we want to use it for, as I mentioned a second ago, which is cohort discovery and linking different types of data sets. And that's what I want to talk to you guys about today. So as of an hour ago, there are 21 linkage honest broker agreements that have been signed. Thank you. That's out of 90 that were sent out. 8 of those sites have, 13 of the sites have hashed the data, 8 of the sites have sent the data. And so I want to, at this point, that minimum point we said was 8 to roll out mortality data. So that's what I really want to talk to you about, what we need next. So, and this is really, I find very confusing. So I'm going to try to say this, but please ask questions, because I think it's very counterintuitive. A data contributing site is sending us their N3C data. We, as part of the linkage honest broker agreement, you, the data contributing site, can agree or not agree to allow NCATS to include your data set, your N3C EHR data set, in the linkage, allow us to link it to another data set, in this case, mortality. If there is another data set, for instance, imaging or viral variants or CMS data, all of those are coming, you as a site get to say yes or no to each data set. So you're seeing a picture of a screen that when I send you an email, it will take you to your site's data contributing website, only yours. So if I send this, and this is University ABC, the link, they would only see their permission. So this is called the site permission dashboard. And when you get there, it's super simple. You click on the link, it takes you to here. You click the edit button right here. And then this becomes a toggle, yes or no. So in the case of mortality, the email I'm about to send out to you is for sites who have hashed their data. So only the sites that have hashed it, those 8, and sent it. We would like you to go in now and change this to a yes, if you are willing to. So it's, again, it's voluntary. And then the edit button will turn into submit, and you hit submit. So that's why there's a 4-step here, but I don't show it. So it's really simple. Link, hit the edit button, toggle this to yes if you want to, and then hit the submit button, and you're done. Really, we want to make it as simple as possible. And the people who are going to get the email, I'm sorry, is the identified scientific lead. All of the PPRL sets, much thanks to Chun Li and Rafael Fuertes, they have are in Chun-Li's external data sets. They're there to read about. So when you get into that site, there's a link there, and you can read what you're getting, you know, what mortality is and what you get out of it and all the licenses. So all of the sets will be linked, and mortality is already up there. So I just want to explain a little bit, because what I was saying a second ago to kind of hopefully not beat a dead horse, but because I do find it confusing. So here's an example. So, and these are all made up, these are all fake. So let's say we've got 3 data contributing sites. They've signed a DTA, they're sending us their data, it's available. One is University of Florida, one's University of Maryland, one's University of Texas. And I say, hey, site, would you turn that on if you want? Again, voluntary. So in this example, Maryland never changes their toggle, their permission. They leave it at no. But Florida says yes, and Texas says yes. So there is a data set that we have purchased called mortality. And what you're giving us, again, the ability to link your data to this other data set, the external mortality. And in this example, and this is kind of silly, there's one person at each site, 1, 2, and 3. And just FYI, and we'll talk about this a little bit more in a second, each in the mortality data set, there's actually 3 pieces of information from 3 sources, because mortality is very fragmented in America, and getting the truth is sometimes hard. And so the investigator will actually see data from a group called obituary.com, privateindustry.com. It's not a private industry, that's the name of it. So Security Administration, you'll see the date of birth, the date of death, their sex, and the state that it came from. In this case, and the same thing with more, you know, here's another person with those 3 feeds from Maryland and 1 from Texas. But in this case, Maryland said, no, we're not going to allow you to link it. So when we do the weekly build, okay, of the N3C data set, when that is done, Maryland's data will be there. It just won't be linked to this table. So in fact, the reason we chose mortality is because mortality is already a data element in N3C. It's just not filled in very much. So we thought this was a very conservative way to start. It really should be there already. And we're not really giving any new information. But in this case, if Maryland said no, you would not see this data at all. You would see the death table, which is part of OMOP, which would be blank or not blank, but you wouldn't be able to see this link table. So I hope that makes sense. So what you're giving permission to, again, is to make this link, right? But even if you make that link, doesn't mean that the investigator can see it. They still have to go through the DUR. And the DUR is going to have a new thing in it. It's going to have a drop-down box with all the PPRLs that are available to choose from. So in this case, we've only got 1, so it's pretty simple. But if there were more than 1, you would have more than 1 checkbox, because you could ask for more. So when you're asking for data sets, in the case of privacy-preserving record linkage data sets, you have to ask permission to get it. And the reason that this is different from the external data sets like census, where those were linking to pollution in a zip code or county, this is actually linking a specific person. So it is at the same level of limited data set. It requires a letter of determination, and in your rationale, you should explain why you're using mortality. So when the DAC is reading your application, it doesn't have to be long, but you have to say why you're using it. And that's how you'll get access. So at that point, when that person, that investigator now got permission from the DAC and the letter of determination, everything got approved, when they look in the new version of this week's build, they will see a link to the Florida data. Mortality will be glued to the Florida, and it will be glued to the Texas, but you will not see that mortality data at all for Maryland. So in fact, for the investigator who can see this, and for the sites that it's linked, you will actually see a view of, not this is again one person, but what you'll also see what's in the common data set, because actually there could be data there. And then in a few next quarter, when we have CMS, you'll see yet a fifth line, because it's very possible that the data doesn't match, right? And these are just contrived use cases, but the date of death for this person, the Social Security Administration, is 1 day off. So you would say, hey, as an investigator, you would probably say, that's probably okay. That makes sense that, when the person was actually documented. But let's say the date of birth was actually, 40 years off, then you may say, I don't want to include this. So it'll be up to you, the investigator who has access to this table, to decide whether you want to include it or not. The harmonization team is working hard on giving you a confidence level, but right now it's just to a large degree, you as an investigator try. This is considered supplemental information. Okay, I'm going to quickly change tacks here and say, so you all probably, we're going to talk about viral variant. This was being rolled out at the same time. There are 10 sites now who have agreed to give us viral variant data. That was going to happen after mortality. And we were just working through it. We're all real happy. But as you all probably know, that Omicron is predicted to be the dominant variant in the United States in early January, so 3 weeks. So I feel like we have a bit of we have an emergency, and something that we could actually, I think, contribute an enormous amount to. So there are sites, I just want you all to know about this, that are going to be sending us viral variant data. And the variant data, the summary will go to N3C, but the sequence with the PPRL will go to NCBI. So once this interconnect agreement is signed, if you have access to it, you will actually be able to go to the sequence data. Even if you don't go to the sequence data, you will still be able to see the variant summary data in N3C, given the permission. So it's just like the mortality. So if you are one of those sites that is signed up and giving us a hash, you're going to get mortality. But if you're also one of those sites that's giving us viral variant data, the 10 sites, you will see 2 lines, one that says mortality and one that says viral variant. So you click the edit button and you make either one or both yes. And again, when that happens, when we turn that on, there will be yet another checkbox, and you can pick as many as you want. So I just wanted to know that we're rushing the viral variant data out because of this pending public health problem. And I think that's, oh yeah, I was going to say one more thing. The viral variant data, Kristen Costa from the OMOP team has been helping us. It will be available for investigators in the OMOP tables, measurement and specimens. And I won't go into details, and all of the data won't be here, but at very least you will get that it is Delta, and you will get the date that it was collected. All the other information, because we're getting it in different places. We're getting it from external labs. We're getting it from an internal lab with a different N3C number. We're getting it from an internal lab with the same N3C number. So we will be getting it in different ways and harmonizing it, but ultimately it will show up here. So I just didn't want people to be surprised that if you're one of the sites that you are doing viral variants, you will see 2 things. And then, of course, when we get CMS, you will see 3 things. And when we, image, you'll see 4 things. So each time we add a new data set, you'll see another row. So that was it. Expect an email from me. I hope that was clear as mud to everybody. Any questions?
There's a question from Rob in the Q&A, Ken, about IRB.
Yes, okay, the IRB. This is a good question. So the data in the N3C enclave that NIH is the stewards of is under the NIH protocol. And I have talked to them many times about this, and they consider the data that is part of the N3C, which is under the same rules, same code of conduct as part of the enclave, and doesn't require us to change the protocol for the NIH or Johns Hopkins. However, like I said, your local letter determination has to make the call if adding mortality or viral variants is so there's kind of two sides to that coin. Now, we in the future, and I'm not saying this is now, in the future, if we're merging two different enclaves, let's say MIDRIC, the imaging enclave with the N3C enclave, or the N3C with Biodata Catalyst, or all of us in what we've been calling the Freeport, that will require a new IRB.
But the local IRB, the investigator's local IRB can then refer to the type of data and not get into the granular details of where exactly it's coming from, who's contributing, who isn't.
Right. And just be sure, I just want to repeat this, your site only sees what you've given permission to. We never give other sites the ability to see what, Joel, in your case, Stony Brook, you said yes or no with mortality, or yes or no with viral variants. That's private and just up to you guys.
So there's another question about Omicron, and in particular expanding on work related to this. Obviously, variants are an incredibly timely thing.
And one other thing is that if you are an existing DUR, and now you want to go back and say, oh, now I've got mortality available, and you want to add it, we will modify the DUR. It's basically a modified renewal. You'll go back in, it'll pull in your whole thing, you're going to alter your rationale, and you'll add one of the external data sets. And you still have to get a new letter of determination, right? Because you are adding something, but we will try to make it as easy as possible for you to just kind of just cycle back with your existing DUR, if it makes sense, right, to add mortality.
Excellent. Let's see. So there's a message in the chat from David Sauer. Can you read that, Ken? Let's see. Cites the plan to contribute sequence data. Do we have a clear sense of the proportion of isolates that are being sequenced? A poor man's way of presumptively diagnosing Omicron, as you know, is S gene target failure in conventional PCR, but that isn't perfect. Okay.
God, you are so out of my wheelhouse. I have no idea. The data will, it's not, I wish I could answer your question. The data that is the requirement, when we give you that data, we work with NCBI, who will be storing the sequence data in dbGaP, and it'll, whatever normally goes in dbGaP, and we will give you those requirements will be in there. So I think the answer is yes, just because I know that it's part of that data, but I can't answer you specifically because I don't know this. Is that a half answer good enough? Or anybody who knows how sequence data goes into National Library of Medicine, NCBI, may be able to help me out. Oh, thank you, Leonie. Yes, only summary data will be in N3C. That is true. So it's, John Doe has Delta, he has Alpha. That's what I know we'll get that. We don't, every lab is going to be different, but we know we'll get that at least. And we'll put that free text in the OMOP table.
And the isolates identified, it'll be an NCBI. Okay. So Melissa, you've got a hard deadline as well.
Yep. So why don't I go ahead and get started?
Okay, thanks, Ken. That was really excellent. It's very exciting. This is incredibly, I mean, we knew PPRL would be important, and it certainly is.
Okay. Thank you.
Okay, let's see. Yes, very exciting. Okay, here we go. Too many things open. Can you all see my screen? I'm going to put it on present mode.
Yep.
Okay, terrific. So I know we are scheduled to do a longer scientific overview of the work we've been doing on long COVID in January, I believe. So this is really just an update on the very long process of obtaining money through the Recover program, and we are very pleased to announce that we have in fact been funded. So N3C is one of 3 EHR consortia that have been funded through the Recover program. And so I'm just going to give a very brief update, and we have some suggestions for the community, and would welcome questions, comments, contributions in any variety of means. We tried to keep as many of the sites that were originally part of the original proposal back in March on, but unfortunately the amount of funding is substantially less than the original request. So I also wanted to just let everyone know that we are very excited to participate and contribute to anyone who is seeking funding for their particular work. We have a number of really exciting projects coming out of the domain teams and are happy to write letters or provide content as you all need, as well as to support sites requesting additional funding for their data preparation and data enhancement. So please do let us know. It may not be part of the Recover program, but we are still very invested in the entire community's participation in the N3C. So don't view this as if your site is not part of the current Recover funding. It's not a forever thing, and it's not the only thing. So I just wanted to make sure that was clear. Okay, so the 5 multi-PIs of our proposal are myself and Tel at the University of Colorado, Chris Shute and Emily, and Richard Moffett, and then of course Anita and Julie, who keep us true to our mission and organize us. So if you have any questions or comments, feel free to reach out to any of us. We are really happy to help. Okay, so of the organizations that are funded as part of this Recover program, they are listed here. Many of the sites that are listed here that we were able to retain are focused on one of a few things. And so I just kind of wanted to highlight kind of the overall scope of what the Recover program is going to cover in terms of our activities. So the first thing to keep in mind is that we, because of the way N3C was funded last year through CURES money, we don't have that same kind of funding this year. We necessarily wanted to include some funding to maintain the data harmonization pipeline and enhancements to OMOP. So we are very excited to have Northeastern and Columbia and Tufts in particular, because those are key partners in our Odyssey community to help us maintain some of the Odyssey components, as well as the Hopkins team leading the harmonization activities and contributions from a number of other sites on the harmonization activities. The second activity that's really the focus of the Recover program is really focusing on doing analytics and having a focused strategy around patient clustering, around identifying comorbidities, around identifying social determinants of health, and on identifying interventions that either exacerbate or ameliorate the long COVID trajectory. And so many of the other sites have been involved in one way or another in those activities. I also wanted to highlight how excited we are to have the patient-led research group participating. And so they are not only have some data science expertise on their group, they're the largest patient organization in the world, as far as I know, and have been leading a lot of surveys and just coordinating research across many different organizations and countries. And so we're really excited to have their patient voice and also sort of a context by which we can kind of vet some of our analysis questions and otherwise get advice on how to kind of think through a lot of the symptomology that we see in the patient community that's not otherwise in the EHR data, and how do we think about combining some of those perspectives. So that's kind of the overview of who's involved at this point for Recover. But again, we welcome contributions from anybody in the N3C community. So I wanted to give you a little bit of an overview of how we ended up where we are, and also just to thank the community, because I know a lot of people have been waiting a long time, and it has been an enormous amount of effort on many people's part to be able to receive this funding. And we're very grateful for everyone who helped, even if the funding didn't necessarily end up being as broad as we had originally planned. So back in March, we applied for the EHR and other real world data RFP, as well as the past data resource core. We revised both of those proposals, and the data resource core at that time, the NIH had decided that they kind of wanted to rearrange a little bit how they were organizing the Recover Consortium, and in particular, focusing more on a hub and spoke model rather than a data resource core that would manage all of the data as was originally proposed. And so in that context, the DRC was awarded to Mass General, and the Clinical Science Core was awarded to NYU. And then there was a new call for multiple repositories other than the electronic health record repository. So this is their idea of the hub and spoke. Instead of having one data resource core that deals with all of the data, they're going to have different platforms for different types of data, such as imaging or mobile health data. And so then, because of that, the nature of that, as I mentioned earlier, we merged parts of our DRC that were focused on the data harmonization and data management and Odyssey activities together with our EHR and other real world data activities, because without that, we wouldn't have the ability to maintain a quality data pipeline and quality data for all of the analytics that you all do. So that's what ended up in the final N3C EHR proposal. We have PCORNet and PEDSNet have also been funded through the same mechanism. And we have collaborated on some collaborative planning around how do we collect requirements and queries from the community that are the focus of the analyses, and then how do we sort of disseminate those results in a consistent way across the different groups. And I think, and so this is just sort of where we are today. We are now a subcontract from the Clinical Science Core, so they are the ones responsible for us. And we have our milestones and payments all go through them. And we now have our signed contract just as of November. So I guess I just really want to say again, thank you to the entire community who's helped us so much through this very complex process. We are so glad to be on the other side of that, and really kind of ready to do the deep dive on long COVID. So towards that end, I wanted to highlight this manuscript that we have in preprint that was led by Emily and Andrew, and it is currently under review, and we look forward to using this this sort of machine learning classifier to identify potential long COVID patients within the N3C cohort for many other different kinds of analytics. And so if you're interested in studying long COVID and you want to potentially use the cohort defined by this machine learning method, we'd be happy to talk to you and happy to think about the best ways to collaborate on the use of this, and also just to improve it over time. And I'll get to this in just a second. And so I'm going to hand this over to Emily. This machine learning method required validation through the presence of patients that had attended a long COVID specialty clinic. And so we are potentially looking for additional N3C data contributors that might be able to contribute such information if you happen to have a long COVID clinic. And Emily, you want to take it from there?
Yeah, so as all of you know, if you are already contributing data to N3C, the phenotype team way back in the day came up with both code and sort of data structures that we disseminated to all of the sites using all of the data models so that the data would come in looking in a specific way, and we could consume it with our pipeline and have it come out nicely on the other end as a harmonized OMUP data model. For the long COVID effort, we've come to realize that there are additional variables that could be very, very valuable to have specifically to study long COVID, things that we may not have thought about before in the beginning of this project. And in addition, there are other variables that are not necessarily specific to long COVID that we think would be great to have as well for COVID research in general. And of course, they may have implications for long COVID. So I'm going to just talk very briefly about a couple of those. I think there will probably be a session of this meeting later down the road where we will talk about this in much more detail. Could you go back one slide, Melissa?
Yep.
Yeah. So there's a link on this slide that will take you to a wiki page, and it's the same wiki that we've been using for all of our other phenotype documentation that will show you how so far the phenotype has designed, if you did want to submit your patients who have long COVID clinic visits, how you would submit that data to us. And right now we have 4 sites that are submitting these data using this data model. And if you would like to join those 4 sites, I encourage you to check out that wiki. Feel free to reach out to me with any questions. It's a pretty straightforward data design and structure, so it's not, from what we've heard, it's not a huge amount of effort to add this to your data feed. So certainly it's something that is voluntary, but if you would be interested in joining us, please let me know. And the next slide. Similarly, the NLP pipeline for an N3C has actually been around for some time. It's led by our Mayo colleagues. I think I saw Hong Fang on the call earlier. And we now more than ever need sites to be pilot sites for that NLP pipeline implementation, because so many of the long COVID signs and symptoms are things that are found in the clinic note as opposed to the structured data. And so at the link on this slide, you'll get to another wiki page that details the NLP submission process. And that is a bit more involved than the long COVID clinic addition to data payloads, but the Mayo team offers office hours and individualized support for sites, much in the way that the phenotype team does, and all of their contact information is available on that wiki page. And so if the NLP pipeline is something that you're interested in implementing, please check that out and reach out to Hong Fang's team. I think I'll hand it back over to you, Melissa.
Terrific. Thank you, Emily. So also, again, I mentioned our patient-led research group, and they, some links on this slide to some of the work that they have done, are interested in patient participants and additional survey data. So those are a link to the survey for people who got COVID but never got long COVID, and also people who got long COVID and recovered. And so that's sort of a kind of a control for doing some of the sort of combined patient contributed data together with the EHR data as we start to think through that. And then also folks who never got COVID, and trying to really think through controls through the lens of patient-reported outcomes and conditions. So we just wanted to make a plug for their work on those surveys, and then hopefully in the future we can come up with some good strategies for combining such data together with our EHR data. And then also just wanted to make a plug for anyone who's interested in contributing community-generated hypotheses around long COVID. If there are things that you think are important to collaborate or work on together, we can. We are absolutely excited to help further the work on long COVID across all of the different domain teams. There's almost no domain team that doesn't have some effort in long COVID when I look through all of the DURs. And so just wanted to provide another venue to supply any kind of ideas that anyone might have, and just to try to otherwise coordinate where we can across our now very large community. So you know, again, we've decided to have a regular monthly update on the long COVID work in general. So once a month on the community forum, we will be seeking contributions from the community. Anyone who's working on long COVID doesn't have to be specific to the Recover funding, but just wanted to give the community an opportunity to show off what they've been working on, and to try to coordinate across our various efforts. And so with that, we can take some questions if there are any. Thank you, David. I see your comment. Any other questions, ideas?
Great idea, monthly Q&A on long COVID. Yeah, I think that bringing in, I think it's a great idea to be very systematic about bringing in thoughts and suggestions from the different domain teams on this to sort of link all of this together. This is really exciting, and And incredible work the MPIs on this have done in actually making this happen. But it was a 9-month, 9-month marathon. It's quite remarkable.
Yeah, I definitely want to make sure that just because we have, I mean, obviously the size of our community, we have funding sources from many different venues, but keeping everybody coordinated is still really important to maximize our efficiency and efficacy. And so I'm hoping that doing that monthly for long COVID will be helpful. But if anybody has any ideas, please, by all means, let me know. It's just getting very complex.
It's certainly one of the things that I think is going to be really important from the different domain teams is to think through the characterization, the many characterizations of long COVID, because I mean, it's a wonderful idea to start with the clinics and model on that, but I'm sure that there are many, especially further out manifestations, characterizations that are going to be important. So the feedback between phenotyping and NLP and bringing in the information and the domain teams is going to be really, I think, obviously very important. So
Yep.
question, any description you could provide software technology used in your project?
You know, I would say right now to date, there is nothing unique to the long COVID work outside of what's already deployed within the enclave. Or you ask, is Ali asking about the enclave technology in general?
Sure, Ali. Yeah, I don't know.
You can also, and then also, let's see, what are the best resources for new info on long COVID for non-medical folks or med students? That's a good question too. So I guess maybe I'll just speak a little bit to each. In regards to machine learning and AI. So I'll put the link to the preprint if you want to see the machine learning methods that we used for that work, but we are in no way limited to those. And we have many other different kinds of activities going on. So, you know, if you're interested in that, yeah, we can definitely clue you in offline. As far as the medical, non-medical folks or med students, there's a couple really nice review manuscripts on long COVID that we've participated in. And then also the patient-led manuscripts are also a really good starting place for sort of non-medical folks to learn about that perspective. And we can put those links in the chat as well. Let's see. Any other questions or comments? Here's this one.
Oh, thank you. That's great.
And then here's the patient research group that has this link, has links to all of those manuscripts as well. And then there's another paper here that for the kind of med student or non-medical people is also a really nice overview. If I can, that's not letting me paste now for some reason. One more link, here we go. There we go. So those are maybe some resources, but feel free to ping us on Slack and we have other additional resources that we can help provide or look on the COVID N3C website as well. Great.
Wonderful. Question, are you seeing more UO 9.9 in the data set? Is there direction? So yeah, this has to do with coding use.
I can answer that one. So, hey, Rachel. So we are seeing more UO 9.9 in the data set, and that's something that we're going to be working on characterizing more as part of the recover work, because we really still don't quite know. And just for those of you who are not familiar with that code and don't speak ICD-10, which good for you, UO 9.9 is the ICD-10 code that was designed to be used to code officially long COVID or post-COVID syndrome. And It's unknown to us how well that code is being used, how thoroughly that code is being used, and at what sites it's being used. So we still see that it's only being used at a small subset of our 67 sites. Part of that is because it only came out on October 1st of this year, so that wasn't that long ago. But there could be other reasons as well. I've heard anecdotally from other sites that they are using alternative codes other than U09.9, codes that they were using before October 1st, they've just continued to use. And so figuring out what that looks like in our data and what those patients look like and whether those patients look different from patients that maybe get coded in a different way is absolutely going to be a big part of the recover work.
Great. So there was a question from Francis Weaver, who's fielding the surveys involving COVID, long COVID, and people with no COVID? Is this something that you'd like more respondents?
Yes, we would absolutely like more respondents. I'm not sure if anybody from the patient-led research group is on the phone right now. But if you go to the link that I pasted to their website, there's lots of contact information, or feel free to reach out to me on Slack or email, and I'm happy to follow up to make sure that we can do that. We absolutely need more respondents. We haven't sent this out directly through N3C sites, but that is something that we could consider. And so I will bring that up with them. They're also considering making some additional surveys or revisions. And so it might be good to get some feedback on what has been done to date and think about what the next steps might be if we want to try to evolve some of the data capture. So Francis, we would love to hear from you if you want to follow up after the fact. And I apologize, I have to hop off and go deal with childcare. So
okay, well, thank you, Melissa. This is, and Emily, that was fantastic. This is really, really good.
Thanks, everybody. Really appreciate it.
Bye.
Bye.
So okay, so we've got and Emily, do you have anybody else have any comments to wrap this up?
I don't have any additional comments, but if there are additional questions, I would be happy to field them, or feel free to Slack me, email me, other modes of communication, carrier pigeon.
Yeah, we actually have a PPRL version of carrier pigeon. They carry hash codes. It's very clever.
It washes windows too.
Yeah, and then we've got they evolve as well, so it creates a sort of and anyway. So Ken.
Thank you. I just thank you, and please, if any questions for me, also please send them my way.
Thank you. Okay, so we have next week's community forum presentation. So let's go, Usman, if you could show the slides, if you have those handy, perhaps.
Give me 1 second. All right, you see my screen?
Okay, yes, beautiful. Okay, so December 20th, immune responses to COVID-19 vaccination in people living with HIV. Oh, okay. That should be interesting, important. So then what we've got winter holidays, and then what, January 10th and 22nd, who has long COVID, big data approach, monthly recover long COVID project team updates. That looks good. Okay, so we have a lot of things coming up, and then what, January 24th, 22nd. I'm a little confused. Okay, January, what is, 22.
It's 2022.
Oh, 2022. Okay, all right, that's right of me. Okay, associations between HIV infection, clinical spectrum of COVID-19, population level analysis based on U.S. national COVID cohort data. Okay, wonderful. And then we have January 31st, findings, recommendations, best practices for multi-site EHR-based clinical research empowered by analytics such as NLP. Okay, so Hong Fang and Sun Yang Fu will be talking about that. And obviously the NLP and long COVID obviously are going to be really, NLP is going to be a critical technology. So this is going to be, I think, a lot of ongoing discussion and brainstorming about that. All right, well, thanks So let's see, do we have any other comments or questions or thoughts? Okay, I think we could probably dispense with the intro of how many patients there are. It probably hasn't changed that much in the last week. So this was a great session. I want to thank everybody. Any last thoughts? Okay, well, everybody have a great week, and thanks for coming.
Thank you.
Bye-bye.